Hello and welcome to Perspectives in Professional Psychology. I'm Dr. Lance Garrison, Dean for the College of Professional Psychology at the Chicago School. Join me as we explore the cutting-edge work of our faculty, alumni, and students across a diverse array of specialties within the fields of professional psychology. Today on Perspectives in Professional Psychology, we're joined by Dr. Reneh Karamians, core faculty member in our Clinical PsyD program in Los Angeles, California. Dr. Karamians is a graduate of Pepperdine University and completed his internship at the Erie Consortium, where he worked primarily in physical medicine, serving as a neuropsychology and rehabilitation psychology intern. He then moved to complete his postdoctoral training at the Ohio State University's Wexner Medical Center, where he continued his clinical work in physical medicine as a rehabilitation and neuropsychology fellow. During his time at Ohio State University, Dr. Karamians worked alongside experts in the fields of traumatic brain injury and stroke rehabilitation. He also participated in various capacities within two model systems projects, including spinal cord injury and traumatic brain injury. Dr. Karamians' most recent publication, entitled Effectiveness of Virtual Reality and Gaming-Based Interventions for Upper Extremity Rehabilitation Post-Stroke, a meta-analysis, was published in the Archives of Physical Medicine and Rehabilitation.
Hello, Dr. Karamians. Thanks for joining us today. Maybe we could get started with you just telling us a little bit about yourself and your background and the role that you have with the Chicago School.
Sure, yeah. So I have been with the Chicago School for, I think this is finishing up my first year as a core faculty member. My background, I graduated from Pepperdine University myself, master's and PhD, or ID, Doctor of Psychology. And then my undergraduate degree is from Ferrum College in Virginia. After graduating from Pepperdine, I went to the Erie, Pennsylvania Psychology Consortium for internship, where I served at the University of Pittsburgh Medical Center, and then Health South of Erie, which is a physical rehabilitation hospital. And then for postdoc, Wexner Medical Center, Ohio State University, Wexner Medical Center. Dodd Hall was the rehabilitation unit where I served as a neuropsychology, rehabilitation psychology postdoc for 2 years. I did stroke research there, some traumatic brain injury research there, some spinal cord injury research. So it was quite a bit of research and quite a bit of clinical work.
Well, with your background, I know that today we were hoping to get some of your insights on stroke. So maybe could you start with telling us a little bit about what the different types of strokes are and some background on what causes them?
Yeah, so yeah, the word stroke is used, colloquially in many ways, but there's several kinds of stroke. There's the two primary kinds are the two most common are ischemic and hemorrhagic. Back in Ohio State, when I used to give these talks to the families, we would call ischemic strokes clogged pipe problems, as if the kitchen sink is clogged, and then hemorrhagic stroke as a burst pipe problem, as in the pipe is now burst and the kitchen is flooded. So there are essentially two types of ischemic stroke. There'd be thrombotic and embolic. Thrombotic is caused by a thrombus in an artery where stenosis of the artery or narrowing of the artery occurs, occluding blood from irrigating parts of the brain. And then embolic stroke is typically the thrombus is somewhere else, perhaps in the deep arteries and veins. And the thrombus breaks off, a piece breaks off from the thrombus, this is essentially the fatty material that constitutes cholesterol. And so that breaks off and then works its way up through the vasculature. And then as it reaches the small vessels of the brain, gets stuck essentially and occludes, and typically it occludes the middle cerebral artery on the left side which irrigates large portions of the left hemisphere of the brain, which are primary speech areas. So those are the two kind of ischemic stroke. A hemorrhagic stroke can happen anywhere. Typically, there sometimes is an aneurysm, which is like a bubbling of, you might remember back in the day when we had hoses,
Hmm.
uh, the hose would bubble up if you left it on for too long because of the pressure. So that happens with the artery, and then that bursts, and then the blood just kind of spills out.
Okay.
That would be a hemorrhagic stroke. Much more severe and poorer outcomes with hemorrhagic stroke than ischemic stroke as far as rehabilitation outcome.
Okay. So maybe could you tell us a little bit about what some of the functional impacts of a stroke are, and whether or not there's kind of different types of functional outcomes? I know you said that a hemorrhagic stroke is more severe, but are there different functional outcomes for an ischemic versus a hemorrhagic stroke?
Yes, there are different functional outcomes. Like I said, with the hemorrhagic stroke, you get typically some diffuse damage to the brain. Um, with that, it's sort of a crapshoot of what's going to happen. Typically, whether it's on the left side or right side, the damage is pretty diffuse. So you're going to get a wide range of symptoms. With ischemic stroke, you get some pretty uniform symptoms. You usually get what we call contralateral hemiparesis or hemiweakness,
Okay.
probably more hemiweakness, which means whatever side the stroke is on, the opposite side, you're going to have weakness. And so with stroke rehabilitation, we try to have different methods of kind of working that other side. So if it's on the left side, you're going to have right side weakness. Working that right hand in physical therapy so that those pathways that have been interrupted because of the poor irrigation are kind of built back up to some degree. And then an occupational therapist may also work on some compensatory strategies if the patient isn't going to reach 100%, get back to 100% functional status.
Sure. So the role of a neuropsychologist in the post-stroke functional evaluation and intervention. Can you tell us a little bit about that?
Yeah. So the role of a neuropsychologist on a rehabilitation hospital, specifically the stroke unit, would be um, there's a lot. So
Yeah.
so first of all, most strokes, like I said, are on the left side, which means the speech areas are affected, which means there's going to be usually some sort of at some level of aphasia, either Wernicke's, which means they can't really understand or even produce language. They'll produce fluid word salad, which means just random words, but nonsensical. Broca's aphasia, which means they have a very slow stutter, but they are able to communicate somewhat, or more than likely global aphasia, which is both Wernicke's, which have very difficult a lot of difficulty communicating. So one of the jobs initially is for the neuropsychologist to determine on an initial exam how much the patient can understand. And we do this with various kinds of qualitative tests. We ask them yes, no questions, give them commands to see if they can follow commands. And then we do that so that we can tell the team, okay, well, here's the level of communication. Here's what they can understand.
Mm-hmm.
So physical therapist, if you're teaching something, here's how you teach it. Or maybe hold off on teaching this until later when some healing happens, some recovery happens. And then, once the patient is ready to discharge or closer to discharge, we want to do a kind of a more thorough neuropsych evaluation to determine if they'll be able to drive, if they'll be able to manage their finances, if they'll be able to live alone,
Sure.
all kinds of stuff like that to make sure that we're not myopic and we discharge the patient and it's safe for them to go back. And of course, we take care of, we have them come back and do neuropsych testing if necessary, if there's something, a degenerative process, or if there's an additional stroke. So those are all kinds of what we do.
So through kind of an initial objective evaluation process, helping understand the full scope of the functional impact, and communicating that to the multidisciplinary team that wraps around stroke patients. And then as they kind of move through and toward going out of a hospital or a rehabilitative setting, helping kind of evaluate their readiness in terms of activities of daily living and their ability to care for themselves properly after, moving out of rehab and trying to go back into a more typical home setting.
Yeah, in addition to that, recommendations for compensatory strategies,
Yeah.
things like that.
Okay. So if someone's outside of a medical setting, what are some of the signs and symptoms that a stroke is happening in the moment?
Yeah, so the signs and symptoms would be to remember the acronym FAST. So FAST is face, arms, speech, and time. So first thing to look for is a facial droop, because either side, right or left, one side is affected. The contralateral side, again, the opposite side, will have some sort of a facial droop because the muscles essentially go limp on that side. So there will be a facial limp, kind of droop on one side.
Something
So
you
that,
can visually see
yes,
and feel.
yes, absolutely. You can visually see their eyelid go down, and their lips go down. You can visually see it typically. And then arms, there's again going to be hemi weakness, right? So if it's on the left side, one side is going to be typically the side that's drooping. That side is also going to be weak. So have them raise their arm. Raising their arms, one might be lower, meaning that they're not able to get it up, or just have them squeeze your fingers and see if the strength with which they're squeezing your fingers are equal on both sides. And usually, if it's a left side stroke, for example, the right side will be weaker, which is unusual because most people are stronger on their right hand. So that is arm. Speech, again, 75% of strokes are left side strokes, middle cerebral artery. So speech is affected. You're either going to get word salad, which is just gibberish, sometimes even non-words, words that are not words, sounds that are not words, or a very severe stutter where they're answering one word, just one with one word.
Yeah.
So that's speech. And time, we're talking about the thrombotic window, essentially. We say time is brain, meaning one, note the time. As soon as you see the symptoms happening, check your watch, see what time it is. The thrombotic window is the window in which a medication called TPA can be administered, okay? This medication is essentially a blood thinner and is a lifesaver. And more recently, the thrombotic window has been extended to 4.5 to 5 hours. So if you get to the hospital within 4.5 hours to 5 hours, TPA can be administered, and the physician should know that, because if the thrombotic window is closed, it's dangerous at that, or it's not effective, at least, to use TPA. So note the time so that you know when the thrombotic window opened and when it's going to close, so that you can tell the physicians. If the patient has taken any blood thinners like aspirin or anything like that over the counter, make sure you tell the physicians that. Sometimes people will have some kind of a heart condition or a stroke, and they'll take an aspirin because that's what they hear on TV. Take all the medications with you to the medical center, to the hospital. But the most important thing the takeaway from this is it is an absolute emergency. Immediately seek emergency medical services. And because the sooner you get this person to the hospital, the better the outcomes are going to be. And, there's a good chance that they could get back to 100% if you get them to the hospital very quickly, and the occlusion is resolved quickly. So time is the most important thing in that.
Yeah, there's just no messing around, right? If you see any of those fast symptoms, it's immediate, act as quickly as possible. And I can imagine that for a hemorrhagic stroke, that time becomes even more critical, correct?
Yes. For a hemorrhagic stroke, the patient will probably lose consciousness relatively quickly.
Yeah.
Unless it's a very slow bleed, that could take some time. And then again, things would just very rapidly within maybe an hour or so, every hour just get worse and worse. It's not an insidious kind of at all. It's rather an acute thing when you have a hemorrhagic stroke. And loss of consciousness is probably going to happen relatively quickly if it's, unless it's, again, sometimes you have a very, very slow bleed, and it takes a long time to even see it on CT, so yeah.
Either way, calling 911 immediately is the best thing you can do.
Yeah, calling 911 or just getting the person into the car and driving them to the nearest emergency department yourself.
Okay.
That's that. If depending on where you live, that might be faster. So if you live in a remote area, the ambulance has to get to you and then go back. So it might be quicker for you to just get that person there. But make sure you get all the medications that they on, take them with you so that the physicians can note the thrombotic window, let them know, call ahead, call the emergency department ahead if you're driving there. Say we have a stroke patient coming in so that they can prepare. Typically they have some sort of a protocol, they call a stroke alert, and there's some sort of a protocol in place. And so all that can just really make a difference.
So with this, I think, it's important to understand what some of the risk factors are for stroke as well, right? So can you talk to us a little bit about what kinds of things increase risk for someone to have a stroke?
Yeah, so essentially everything leads back to high cholesterol and high blood pressure. So things like smoking, poor cardiovascular health, just in general, just being overweight, being obese, not getting enough exercise, these are all risk factors, but basic poor diet, smoking, drinking. I mean, these are all risk. But essentially, what it gets back to is what's causing high blood pressure and high cholesterol together are essentially the cause. So there's lots of risk factors. But if your blood pressure and your cholesterol are under control, you're at much lower risk for to have a stroke of any kind.
So there are a number of kind of lifestyle types of issues that can converge to increase an individual's risk for stroke.
Yes,
But
absolutely.
they're all kind of drive towards cardiovascular health, correct?
Yes, a poor cardiovascular health, and you can fact check me on this out there in TV land. Cardiovascular health kills more people than anything else, and you can put all the other killers, disease, together, and poor cardiovascular health worldwide still kills more people than all the other stuff put together, probably. I would bet the farm on that, right? So it's all try to maintain cardiovascular health as far as stroke, and you'll be okay.
So I guess on that note, kind of the natural next question, given that we know outside of genetic predispositions to cardiovascular issues, these lifestyle issues that kind of feed into creating additional cardiovascular risk for stroke, what are some preventive measures that people can take?
Yeah, preventative, definitely. If you are obese or overweight, check your blood pressure regularly. I mean, you're resting. So have a seat for about 5 minutes and then get just a home blood pressure cuff. They're pretty cheap on Amazon, anywhere else.
Mm-hmm.
Test your blood pressure. They're pretty accurate. If your blood pressure is high, above a 120 over 80, if it's 140 over 80, that technically is starting to be high. talk to your physician and get the blood pressure under control. Have regular physicals where a blood workup is done so that they can look at your fasting um, blood sugar and your cholesterol, and to see if that's under control, and if not, get that medicated. So medicating blood pressure and cholesterol is important. You know, regular exercise. You don't have to go out there and run marathons, but 2 or 3 times a week, get your heart rate up for 30 minutes. Get your heart rate up, walk 30 minutes 2 or 3 times a week. Avoid things like bad habits like smoking, which can increase your heart rate and all this stuff, and cause damage to the blood vessels. Moderate alcohol use, all this kind of stuff can really help.
Just a lot of standard lifestyle things, right?
Yeah.
Regular exercise, probably can mix sleep in there, getting good sleep, eating, a well-rounded whole foods-based diet. All of those things kind of flow into what could create some opportunities for prevention when it comes to stroke.
Yeah.
And it sounds like if you're at risk too, right? If you have some of these lifestyle issues, or you have, a family history of stroke or other cardiovascular issues, that's another sign that you should probably be working really closely with your physician on putting a plan together to help kind of mitigate some of the risks that you're bringing into your day-to-day life.
Absolutely. Genetics is definitely a thing when it comes to stroke. That is definitely also a risk factor. If you have, mom, dad, a close related family member who's had a history of strokes, you're probably slightly higher risk for that too, especially if you're not taking care of the cardiovascular health. Um, you know, uh, Transient ischemia is a transient ischemic attack is another type of stroke that essentially it's a clog that resolves very quickly. By the time you get to the emergency room, all the symptoms have resolved. If you've had something like that, you're at higher risk. And typically, if you go to the emergency room for that, the physicians will put you on statins and blood thinners and make sure and blood pressure medication to make sure that a real true ischemic stroke doesn't happen. But yeah, genetics is with cardiovascular, just like anything else, genetics is a factor. Yeah.
Well, Dr. Karamians, I really appreciate your time with us today and for you sharing your expertise in this area, particularly kind of the role of the neuropsychologist in this process. I think that's really important. So thank you again, and we'll talk again soon.
Okay. Thank you very much.
Thank you so much for joining us on Perspectives in Professional Psychology. Until next time, keep exploring, keep learning, and keep making a difference in your communities. If you'd like more information about the professional psychology programs offered at the Chicago School, please visit us at thechicagoschool.edu.